Hello friends, this is not just another case of small pupil. In fact, the video is totally unedited from the time I start performing the capsulorhexis. There was small pupils and a very advanced pseudoexfoliation. The patient had zonular dialysis and I needed to use a CTR. And you can watch all this as the case unfolds. The trypan blue is applied by what is called the air trap technique. This helps in small pupils. A small amount of air bubble is injected and few drops of trypan blue instilled underneath the air bubble. The air bubble will trap this trypan blue and prevent it from escaping from the pupillary area. This will help you to stain the capsule well and also the portions of the capsule underneath the pupillary edge. Pay attention to the clear corneal incision because a poorly constructed incision will lead to iris prolapse. Always wash off the trypan blue from the anterior chamber before filling it up with viscoelastic because this will enable you to get a much clearer and crisper view of the anterior capsule while performing capsulorhexis. From this stage on, the video is totally unedited and you can watch the video unfold as it happened on the operating table. I try to keep the capsulorhexis as large as possible and I'm able to create a pupil hugging capsulorhexis. So the reason why I'm taking my time with the rhexis is to see if there are abnormal folds that occur while performing the capsulorhexis, which will give me an indication and a clue that there is some amount of zonular weakness. So I did not see any such sign of zonular weakness and just a small amount of fluid is injected to effect the cortical cleavage hydrodissection. Just 0.1 to 0.2 ml of fluid is enough to effect the cortical cleavage hydrodissection. This is a very important step because if you do not perform this step correctly, then you will be definitely imparting zonular stress, and a failure to rotate will also impair or impede the progress of phacoemulsification. Phacoemulsification is being attempted by the direct phaco chop technique and I am using the multi-burst mode using a very low burst duration of just 15 milliseconds and a duty cycle of 65% in my Stellaris machine. Well, the aim and the plan is to create multiple small fragments while remaining within the central zone and not fishing blindly underneath the pupil. So this can happen, or this is possible when you are performing the direct phaco chop by just impaling the phaco needle or the phaco tip into the nucleus substance and using the sharp chopper to just break this nucleus down into smaller fragments. In a small pupil, always aim to create just more than 4 fragments. So at least 6 fragments would be a good idea because this will help you to a great deal while you are mobilizing the nucleus fragments. So once the nucleus fragments are sufficiently small, then it is mobilized into the central zone and it is emulsified in the plane of the pupil. Well, gently swiveling the phaco needle will cause the aspiration flow rate to propel the pieces better towards the phaco tip, and I found that it improves the followability in my hands. So while creating the small rotatory movement of the phaco needle or the phaco tip, make sure that you face the bevel always towards the fragment. This will also greatly improve the followability of the nuclear fragments. There is actually no risk in performing the direct phaco chop, as you can see that every step that I am performing is totally under my control. I am not taking any additional risks. Even though the pupil is small and I have not used pupil dilating devices, I am staying quite in the central area and I am evacuating the pieces with considerable amount of ease. At this point, once you've effected the crack, it's always better to exchange the sharp chopper with a Sinskey hook because it's easier to maneuver a Sinskey hook in the anterior chamber. If the right amount of aspiration flow rate and the vacuum is set, then the nucleus fragments will come towards a phaco tip and you don't have to go chasing after it into the periphery, which is an important step in small pupils for phacoemulsification. So that's it. The fragments have been completely removed, and now we move to cortex aspiration. I use the coaxial IA cannula for this purpose. Even though the pupil is small, you can see the cortex peeping out through the pupillary area, and you can grasp onto this cortex, make slight side to side movements to free and loosen it from the capsule, and then draw it towards the center. Now this is where I have to reiterate that a good cortical cleavage hydrodissection will go a long way in enabling you to achieve easy mobilization of the cortex. Note at this point, when I am trying to tug at the cortex, something abnormal happens, that I think I got hold of the anterior capsule at this point. Oh, yes, because you see the way it springs back in an elastic way. This will not happen if you are holding on to cortex. So I am sure I have caught the anterior capsule, the inferior portion of the eye, and this could lead to a zonular dialysis, because in pseudoexfoliation cases the zonules are anyway weak. So I stay away from that 6 o'clock position, and I remove the cortex from all other portions of the eye. Pseudoexfoliation patients tend to have a higher degree of postoperative inflammation, and this can be made worse if you have retained cortex. Hence, make sure that cortical washout is done quite immaculately. Now I've got all the cortex out, and because I suspect that I could have created an inferior zonular dialysis, I decide to go ahead and implant the capsule tension ring, 10.5 millimeter ring. This ring is made of PMMA, and it helps to create an equatorial stretch of the capsular bag and helps to support the bag. So I use two plain forceps in order to implant the capsule tension ring. So the first loop is fed into the capsular bag, and then it is slowly threaded into the capsular bag. Normally, the flexed portion of the capsule tension ring should be supported with a second instrument, but however, because the pupil is small, the pupil itself is supporting the capsule tension ring, and this will not cause an abnormal stretch of the capsule, and hence I do not try to support it. So finally, the trailing loop is then also implanted into the capsular bag. I am more confident now that the capsule support is good, and this gives me a higher level of confidence to go ahead and complete the case with the implantation of a hydrophobic acrylic intraocular lens. The lens is injected so that the leading haptic gets into the capsular bag, and the trailing haptic can be simply tucked in. Because of the presence of CTR, the capsular bag withstood the slight stress of pressing the loop into the capsular bag. So viscoelastic is carefully washed out from within the capsular bag. The IOL is then pivot rotated to the horizontal position, and the act of pivot rotation sometimes will free the cortex, or rather many times will free the cortex, and I found that after performing pivot rotation I was able to isolate and remove some more of the cortical material, so that the bag is now completely free of all cortex. The sweep of the haptics during pivot rotation can dislodge fragments, it can free the cortex. It will also help you to align the intraocular lens in the correct position. So the case is then successfully completed without any hitch, and you have seen an unedited version of the entire management. of this small pupil with pseudoexfoliation. I hope you found this useful and it will encourage you to attempt to perform such cases in the future. I thank you so much for your attention.